in New York. So this is very real. This is affecting all of us. It affected our speaker schedule for today. So we are very grateful to Dr. Kaleem Ahmed, who has been a regular attendee here and one of our speakers before, who has kindly agreed to step in and provide a brief overview of updates on COVID-19 infections. In a minute, I will invite him to introduce himself and go for presentation. And then after his short presentation, we will have the panelists introduce themselves. And then we'll start with Q&A with the speaker and panelists taking those questions. Again, write any comments in chat box if you have. Send your questions in Q&A. Raise your hand if you want a microphone. We invite all of you to be participant as speakers and panelists. If you have experience with COVID-19 infection, you can send an email to apnamerit@gmail.com. You can also suggest other speakers who you think will be great speakers, and we can invite them on your behalf, on Apna's behalf, to be a speaker in this platform, and then be a panelist with us. And we really greatly appreciate your involvement and your presence early in the morning. So with that summarization, I will our speaker, Dr. Kaleem Ahmed, to introduce himself and provide a brief overview of COVID-19 infection updates. Dr. Kaleem.
Assalamu alaikum. Thank you, Danish. It's a pleasure to be part of this wonderful group from across the continent. बड़ी खुशी होती है कि जब लोगों से बात करके अब किसी ऐसे प्रोजेक्ट में आप अपना रोल कर रहे हो जहां पूरी दुनिया जो है इस मर्ज को समझने और इसको ट्रीट करने के लिए जो है वो कोशा है, और हमारी छोटी छोटी काविशें शायद किसी इंसान की, किसी महल्ले में लोगों की जान बचा ले. तो very thankful for this opportunity. As you already mentioned that we feel sorry for our loved one in the family who died because of this condition. So yes, it is a real condition, real issues. Everybody is facing this. Today, what I'm going to do is we have been learning. Instead of teaching, we have been learning since we started this project, learning a lot. Major management issue, we focus on a very small segment, which is very, very important, critical, life-saving, but then we take out our focus from the whole disease process. I'm going to give you a little brief, about 10-15 minutes, brief overview of this condition, and then inshallah we'll open up the discussion as Danish has mentioned, and then we're going to see how we could learn from that. So with that, let's start this. So the COVID-19, what exactly the COVID-19 stand for? So COVID-19 is basically a coronavirus disease, which was kind of started in 2019. That's the reason the disease related to this coronavirus, a novel coronavirus, is called COVID-19. When we come to the virology, it's belonged to coronavirus. We could have a common cold. A lot of people can develop this common cold kind of thing with the coronavirus thing. But then there are certain strains of the coronavirus as seen, which was causing significant problem, including the SARS, which is severe acute respiratory syndrome, which was very, very virulent and has caused a lot of problem. MERS, we have learned about that thing, and it also had a similar kind of issue. So this novel coronavirus is belong to the same subgenes of the SARS, but it has a different clade. It belonged to a different ancestor. We're still learning about that. And the similarity is that this coronavirus uses the same receptor of ACE2 receptor in respiratory epithelial cells for the entry. And because of that reason, International Committee for Taxonomy for the viruses has proposed that it should be called SARS-CoV-2, means similar thing as SARS, with COVID coronavirus 2, because it has a little bit different than the SARS, but almost similar receptor. it's this, as any virus, virus changes strain a little bit here and there. About 130 strains so far has been analyzed. Two distinct variety, which is subtype L and S, was reported from China. Clinical significance of that still we don't know, but that is what the virologists will decide about that. When it comes to the epidemiology, so far, it's been reported all over the world except Antarctica. So we have no reported cases so far from Antarctica. And transmission is mainly, as we all discussed, it is from the respiratory droplet, like a flu. Droplet typically do not travel more than 6 feet, and it does not linger on in the air too long. That is the reason the 6 feet distancing has been proposed from many different governments and regulatory agencies and WHO and so forth and so forth. When they did some experimental modeling with the generation of the aerosol, they showed that the SARS-CoV-2 virus has remained viable in the environment for at least 3 hours. And this is the reason in certain condition, when there is a lot of aerosolization, the recommendation from different societies and guideline is that one should be very well protected with PPE, including N95 mask. So the reason is because those aerosolization, a reason for infection for other people. As for WHO and China joint report, there is no fecal-oral transmission has been suggested for the significant disease propagation. Although the viruses has been found in the stool, but infectivity was not documented. There was no viruses found in the urine per se. How long this virus remain infective? So throughout the course of the disease process, the viral RNA has a different kind of the way its infectivity changes, and during the first week, it was found to be more infective than the rest of the time. So infectious viruses are readily, recognized by this technique of RNA detection with the nasopharyngeal swab. And during the first week, they found that you can isolate those viruses which have effective property. But after that, although the virus is still there, but they are not as infective as during the first phase. And they have done some studies published in Nature. They found that the viral replication RNA and its intermediates were reported in the throat swab, but they were not as infective. So these information might be important in future understanding of our different policies and procedures and how to implement those scientific information in reality. When we look into the epidemiology related to this, the duration of viral shedding. So many different studies you can see which is available. And there is a timeline between 8 to 37 days. A median duration was proposed about 20. हम यहाँ बात इसलिए कर रहे हैं कि भाई हम पाकिस्तान में इन चीज़ों को किस तरह से prevent करें. The most commonly it has seen, and again from the China study, the most information we have from there is from the household contact. So the household contact in the early stages of the disease was about 10% in China. Later on, it was in other part of the world, like in Italy and Spain, and even in the United States, it was dropped down to between 1 to 5%. What is the risk? A lot of time people, we all healthcare provider, we have patient, they ask question. So what is the risk of transmission from indirect contact? What is indirect contact? Means if somebody is walking to the grocery store or walking on a street and somebody's passing who has been diagnosed to have coronavirus, just by passing through this, handling the item, somebody is delivering food to you, or a package coming to your house, what are the risks of handling those things? So those risks has not been documented that much, and it is suggested that it is probably very low. Then another thing which we all wanted to know is how we can develop immunity. So far what we know about this is it's take about 14 days to develop the IgG in the system. Close to about 3 to 5 days timeline has been seen in some studies to appearance of the IgM and IgA. Incubation is about 14 days from the time of the contact. So that's the reason most of the time, initially, we were asking patient who has contact to go for self-quarantine. The self-quarantine and self-isolation, these are the two terms used, and sometimes people use it synonymously. I just want to clarify that self-quarantine is that if you are suspected that you are in contact with somebody who has COVID-19 and you are not sure, you don't have any symptoms, so you keep yourself away from other people, distance 6 feet, and not trying to go out too much. That's called self-quarantine. Self-isolation is that if you are positive but you don't have symptoms, you don't have to go to the hospital, then you need to isolate yourself. Then you have to change your lifestyle. अपने खाना जो है वो अपना सेपरेट कर लें, बर्तन अपने कपड़े जो है सेपरेट कर लें, अलग कमरे में रह सके तो रहें, अपना अलग टॉयलेट इस्तेमाल करें, लोगों के साथ जब जाएं तो अपने मास्क पहन के रखें. So all these things are part of the self isolation, which is slightly different from the self quarantine. इसके बाद जो है वो आपका spectrum of the illness and severity. So this is an important thing which I want to stress. So far जो भी हमारे पास स्टडीज आई हैं अब तक, उनके अंदर मुख्तलिफ तरीक़ों से अगर आप उसको स्लाइस एंड डाइस करते हैं तो एक नंबर सामने आता है, वो कि about 81% patient who was diagnosed to have this coronavirus, they have either no symptom or they have mild symptom or mild kind of symptom, which is maybe a little pneumonia or not. And then about 14% of the patient has severe symptom, and severe symptom is defined by like somebody is developing significant pneumonia or hypoxia. And pneumonia is involving more than 50% of the structure on the chest radiograph. And only about 5% people are critically ill. Those patients who either develop respiratory failure, shock, or multi-organ failure. So if you take in general, this is what we are dealing with. About 5% of those vulnerable population is going to require our expertise in taking care of those patients when they are going to be in very, very sick. But 95% of the patient population either going to not require ICU and ICU care, or they're going to require some other form of care which we could provide with the understanding of this disease process. Case fatality rate of this disease is anywhere between 0.7% to 5.8%, depending upon which data you're looking. In close to 2.3% was initially reported in China and where the disease was started in Wuhan. But overall in China, it was 1.4%. So again, fatality, although it is much higher than seasonal flu, which is 0.1%, but this is some number which we need to keep in mind. Then we already know that there are many risk factors for the severe illnesses, and a comorbidity, which we call diabetes, coronary artery disease, COPD, asthma, cancer, chronic kidney disease, advanced age, and obesity. So And people who have seen these people who are going through the severe process, about 2 to 3 comorbidities there, they are kind of at a higher risk of developing problem. The median age for hospitalized patient, again, hospitalization on the basis of the need for hospitalization. And Pakistan, as we heard yesterday, they are admitting patients who may or may not require hospitalization. So, so those patients was between the age of 49 to 56. People who are developing a severe critical illness, there are certain lab findings which are jumping out, including lymphopenia, in some cases lymphocytosis, but primarily lymphopenia, increased LDH, liver enzyme, some inflammatory markers like CRP and ferritin, and D-dimers. There's also increase in PT, prothrombin time, troponin, some increase in the CPK, and development of the acute renal failure. These are the things which were seen in few studies published in JAMA. In US, what we have seen, about 67% of the cases who are admitted in the hospital was more than 45 years old. So a little bit younger population was more than what we have seen in China and in Italy. But 80% of the death occur in US was in patient population who are more than 65-year-old. Asymptomatic patient with infection. So this is another thing which we have to keep in mind. There are patients who are going to be totally asymptomatic. As I said earlier, 81% has a mild symptom or no symptom. The best data which we have in a confined environment is Diamond Princess cruise. Everybody heard about that. There's a cruise line where infection was started in Japan, and that was a perfect case study. So out of that, about 17% of the people who are on board were tested positive for COVID-19. But only 50% out of that, which is about 619 confirmed positive patients, they were asymptomatic. They had no symptom at all, despite being positive in a confined environment. And then the same thing is even in the very first large group of patients was involved in Seattle, in King County, Washington, Seattle nursing home. There was 13 patients out of 23 total positive were asymptomatic initially when they were tested. But later on, there are some more patients who are asymptomatic that became symptomatic later on. Interestingly, when we have seen the CT radiographic data, even patients who are asymptomatic, they could have, in up to 50% of the time, they could have some type of radiological abnormality in the CAT scan. So these are the things which I want to make sure that we can cover this thing in the journal and then go from there. Symptom-wise, the majority of the time, the symptom which we have seen is temperature, fever more than 104. About 99% of the time, this is China data. Fatigue was about 70% of the patient. Dry cough was noted about 59% of the cases. Anorexia in about 40%, same with around myalgia, 35%. And shortness of breath in about 31% of the patient. And there are, we know that the cough is primarily dry cough, but in about 20% of the cases, in one study in the JAMA, shows that they could have sputum production. And also GI symptom like nausea and diarrhea was also seen in about 18% of the patient population. So first time we have seen some studies from Italy where they have also seen the anosmia and the dysfunction taste in about 34% of the patient population. When the disease progressed, the course of complication happened. The dyspnea usually occur about 5th day after the start of the initial symptoms. So suppose somebody has contacted this and then start developing some fever and cough, but the shortness of breath could be the later part of the disease process rather than very immediate symptoms. And then people who develop progressively to worsening of the symptom, they are usually occurring in between 7 to 8 days. But the problem, which we have seen all over, that once they develop the shortness of breath, and those patients who unfortunately develop worsening of the respiratory failure, it happened very quickly, either development of ARDS or other respiratory abnormality. And in some studies, initially when we were reviewing this thing, we thought that everybody is developing ARDS, but then we have seen that there's another form of respiratory abnormality, which is not pure ARDS kind of typical picture, some other complication. And then ARDS kind of thing is now ranging between 12 to 40% on hospitalized patient with seen. Other complication, as you might have heard from our cardiology colleague and our nephrology colleagues, that arrhythmias has been seen in about 17% of the time, myocardial injury with the positive troponin MI occurring about 7% of the time, and shock, circulatory failure about 9% of the time. Again, these data was, there's so many data from different publication. I'm giving you some few of them here. And in about 33% of the people in US in one study who are severely ill in respiratory failure in critical care ICU ventilated, about 33% of them has some cardiomyopathy as well. Pulmonary embolism and a stroke was also reported, and then this microvascular thrombosis, some DIC picture, and DIC and microthrombic related complication of multi-organ failure was also seen. So recovery time from the disease in general is about 2 weeks from the start to the finish in patient who has mild symptom. People who develop more severe and serious condition, it could be around 3 to 6 weeks. And radiographic imaging is all over the place. If you read the American Radiological Society guideline, although there is a classical picture is consolidation, subpleural distribution, ground glass changes, halo sign, crazy paving, all those kind of things are classical, but they suggest that even if some patient, you may not see any kind of radiographic changes, but don't rule out that. Take the patient in journal. And diagnosis, again, by the RT-PCR, nasopharyngeal swab is the best, but it could be negative in about 30% of the time, depending upon when you're doing it, how you're doing it. If somebody is intubated, BAL should be done. Expectoration for the sputum should not be done because of, again, aerosolization issues. But if somebody is coughing up phlegm, then you can use the sputum. Swab could be performed oropharyngally as well. Nasal swab could be done. But the yield of that is variable in different patient population. If you do BAL, the sensitivity is close to 95% in those patients. A lot of people are, hoping to have a point of care serological test. The serological test kits which are available are kind of, their effectiveness is all over. WHO is not endorsing any. FDA has approved several. But again, the accuracy is still in question. Unless we have more data, it's going to be difficult. And management-wise, how to deal with that. So in more than 81% who are mild cases, we just have to do either symptomatic therapy or no therapy, except for self-isolation. If patient develop severe infection, again, there is no concrete evidence. There's a lot of randomized controlled trials going on, and people are using different institutions have different protocols. So you follow your institution protocol. either using hydroxychloroquine alone in combination with azithromycin, although there's a recent publication which is discouraging using both together, especially because of the heart issue and QT prolongation problem. Remdesivir has been showing some progress and promise. Again, it is still an investigative medication, and you should use according to your hospital guideline. Convalescent plasma, again, is something is that this is again an experimental thing. IL-6 inhibitor, TOSI and others, and steroid. Again, we have talked about that in detail on those things. We could handle this thing in question and answer session. Mechanical ventilation, how we could do that. We have a robust discussion about that, and we're going to, inshallah, doing the ventilator course as well. So we're going to talk about that and guide accordingly. So this is just a little brief summary, and I'm going to stop here. And then, inshallah, we're going to start our discussion. And if or other panelists, please jump in, and then we go from there.
Thank you so much, Dr. Kaleem, for a very concise and wonderful summary. I want to request attendees again, for someone like me who is joining after a few days, it would be great if you can introduce yourself in the chat box. I promise I read every single introduction and hopefully remember most of them. Welcome to the webinar and discussion platform. Please use the Q&A box to ask your questions from the speaker, from the group of panelists who will introduce themselves in a minute here. I do have a bunch of questions already to begin with. I also want to tell the panelists, to the attendees, that we are doing a poll right now that you should see pop up on your screen, where we're trying to figure out how to adapt our webinar during the Ramadan timing. I appreciate if you can give your answers here, and then hopefully we can also send this poll out to all our subscribers and registered participants. Dr. Kaleem briefly mentioned that we are working on figuring out if we can develop a basic ventilator management course for our participant. You will see a simple survey come in your email to ask this question, and please respond to those. Based on your response, we'll decide if we can put something together, how useful it will be, or if we can find something that's already going on for you guys for ventilator management. And then before I start with the Q&A today, let me go one by one to our panelists and ask them to introduce themselves. I will call your name. Please unmute yourself and then introduce yourself and then I will get to the questions afterwards. So I will go alphabetically. Dr. Farhan Kadir.
अस्सलाम वालेकुम जी, मेरा नाम फरहान है, मैं नेफ्रोलॉजिस्ट हूँ और उसके अलावा मैं क्रिटिकल केयर यूसीएमसी में कर रहा हूँ. थैंक यू जी.
Dr. Mariam Morton.
Assalamualaikum. I'm Mariam Morton. I'm a staff cardiologist at Loma Linda VA in California.
Dr. Muhammad Salim.
Assalamu alaikum, Janab. I am Dr. Muhammad Salim Khan. I am working as Chief Consultant Physician in Kotli, Azad, Jammu and Kashmir. Thank you.
Welcome, Dr. Salim. It's a pleasure having you. Dr. Kabani.
Good role in this screening, because you see when the patients they entered, they were just thermoscanned, and those who don't have the temperature, they were sent, and it led to the spread of the disease.
Yes, but the problem is that if you want to control any spread of the disease, you have to have some kind of cutoff thing, some kind of parameter. You could not, if somebody is asymptomatic coming from an area where it's a disease process, you could not ban them altogether on the airport. You could not quarantine them. You don't have resources. You don't have test kits. even if you
Yeah.
don't have test kits in the hospital. So there is a balance one has to take. And we learn from our mistake, definitely. And we may come up with something in future which may be more sophisticated, but this is what we have right now.
Farhan, you have a
True,
comment?
agreed.
Ji, so I think I totally agree with Kaleem Bhai. But I think one more thing which I want to add on, that's one of the reasons where universal masking, your social isolation, your 6 feet distance comes in. Yes, those are just the parameters. Okay, we're going to use a thermostat. If you have fever, please stay home, because that's 80% of the patients going to present with this most common symptoms. As in medicine, we always say common things are common. So I agree with you. There are pre-symptomatic patients, but that's one of the reasons we're making sure that everyone should wear masks. Everyone should have social isolation. Those are the preventive measures. On
Great.
top of that, thermostat use.
Let me take some of the attendees into discussion. I see a raised hand. Please go ahead, introduce yourself and make your comments or question.
Hello, I am Dr. Hafiz from Karachi. I'm child specialist. I was worried about how can we decrease the spread. When you say the virus is shed in urine, it was denied by Dr. Kaleem, but in urine and in stool. If patients who are asymptomatic but they are positive, if they do not care properly of their urine and stool, for example, in Islam we clean with water, and that clears our anus area will clean. Those who do not use water, they use only paper. Stool may remain there, and there may be more infection may be over there. Number two, urine. They do not care about the urine. We Muslim use water. So I mean the last drop of urine which comes, we try to clear that out by squeezing the penis from the root, and even that drop we also take care. So if there was virus in the urine, so if those patients will not care of their own stool, their own urine, they will spread virus in the community. Number two, sore throat. When there is a virus in upper respiratory tract infection, as we do in the wuzu, we do gargles, we do cleaning our nose 5 times a day. So I think wuzu 5 times a day and or the Islamic way of taharat will have a lot in preventing the spread of the disease. Or gargles with saline water.
Let me also add a couple of other related questions about the spread as being asked here. One question is that does the virus spread with normal breathing, even if the patient is not coughing or sneezing, even if the carrier is not coughing or sneezing? And then how long is this virus surviving on different surfaces? So let's start with you.
Is for me?
Yes.
Okay.
So transmission,
So,
various routes, survival, normal breathing.
So normal breathing or talking, if you are close to 6 feet distance, normal talking has a chance in terms of spreading the virus to the other person. As far as if you are just passing through from on a street and not come too close, and somebody is having that virus in their body, chances of getting it just by very casual, non-close contact is very, very low. Now, as far as the presence of virus in the other body secretion, they have not seen any viruses in the urine per se. In the stool, yes, but the World Health Organization and China joint statement about the fecal-oral transmission, they said they don't think, on the basis of the data, that this has played any significant role in terms of spreading the disease process. So this is what we know. Now, when it comes to certain practices of different cultures, definitely we do the most important procedures and taharat related thing in our society, and which is a good thing. And whether it is playing a role in terms of preventing the disease process, it's become a scientific question. And the scientific question could only be answered scientifically by doing the study. In the absence of study, we can speculate, we hope, and we feel, but we cannot make it a scientific statement unless somebody in Pakistan start doing that project and look into those practices in our country and other places and come up with a solution.
Dr. Farhan?
Gee, I think I totally agree with Kaleem Bhai. But second thing which I want to tell you that even if it's, let's say for a second we presume that there is a fecal transmission, fecal, even if it's a fecal, the most important thing is again hand hygiene, which
Absolutely.
everyone is telling you. You have to do hand hygiene. There is a reason. It's what Islam tells you, or your religion tells you, your society tells you is completely different what you practice. That's one of the reasons there is a highest amount of fecal oral transmitted disease actually exists in Pakistan, India. And they use the regular taharat or whatever we call the water sanitation. So the most important thing is hand sanitation. You have to use hand sanitation irrespective of where it is coming from.
Very good. And then a quick comment on how long it survives on different surfaces. If you cough or if you breathe on something and you walk away.
I think somebody else should be. I'm talking too much.
Okay, let me call Dr. Morton. Dr. Morton?
The viruses, can you hear me?
Yes.
The viruses tend to survive on different kind of surfaces for different time duration. I don't really know the exact number, but it varies between 2 hours to 12 hours, depending on the porosity of the surface. In plastic, it's supposed to be less. In I think in cardboard, it was a little bit longer, but I don't remember the exact time, but it was between 2 hours to 12 hours. It's posted online at a number of places.
I think plastic is longer and cardboard is less. Am I correct, Dr. Kaleem?
So rubber.
So the study which was published in the New England Journal of Medicine, that was looking at the presence of the viruses, and that was, they have shown that mostly about 3 days or more up to on the surface of the steel and plastic. Cardboard was kind of relatively low, and fabric was almost similar to that thing. There was a study done in a negative pressure room in patients with severe COVID infection, and they tested all different areas like switches and knobs in negative pressure room, and they have found the viruses there. Again, I think the important thing is another thing which I want to add, that even after 3 weeks in Diamond Prince's ship, they found the viral element on the surface, on some surfaces there. Now, that's the reason when I present my overview, I try to stress that the presence of the viral RNA does not mean that the virus is still infective. And that is something which we will learn, hopefully with time, what are the other scientific things which will help us to make a better understanding about this. Oh, somebody has put this very nice thing here. Here you go, on the, share the screen.
Yeah. I think Dr. Morton just did that,
Oh, okay, good. Very good.
So a question from audience from Dr. Noman Tariq about, again, asking some clarification on neutrophil to lymphocyte ratio in COVID infection versus other infections with fever.
So answer to this question, there is a recent meta-analysis published on neutrophil to lymphocyte ratio, including 6 studies, and they also compare neutrophil to CRP ratio in that meta-analysis. And the only thing which it tells us, they never compared the neutrophil lymphocyte ratio between COVID versus non-COVID. They just tell us about neutrophil to lymphocyte ratio, and that actually a bad prognostic indicator, as I believe everyone knows that. But does it tell us that are those patients going to go into shock? Probably yes, because it actually signifies your cytokine storm. But I don't remember that, or I read anywhere that it actually been compared between COVID versus non-COVID.
Very good. So I think we are a little bit over time now, so I'm going to start wrapping it up. And I have an interesting question asked by the audience to try to start wrapping it up. I will probably call opinion from each panelist, and starting from the panelists who have not had a much chance to speak. So the question is about how long do we think this lockdown or social distancing will continue in order to fight or delay the spread of this COVID-19 infection. So I'm going to start with Professor Shamsa Humayun and see what her feelings are or experiences are working in Pakistan about the social distancing and how long it might continue. Professor Humayun, please unmute yourself.
Sorry, I missed your question.
So there was somebody who put a question from our audience about how long we think this social distancing, lockdowns, or partial lockdown will continue to fight this infection in terms of a general sense of feeling among the experts. So what's your sense from working in Pakistan on how long this issue will continue?
जी मेरे ख्याल में जैसे अभी थोड़ा सा इन्होंने लॉकडाउन रिलीज किया तो yesterday the number was doubled. तो probably ये महीना तो social distancing तो मेरा ख्याल अब probably जब तक वैक्सीन नहीं आती we must observe social distancing. लेकिन जो लॉकडाउन वगैरह है वो मेरा ख्याल है अगर ये केसेस पाकिस्तान में नीचे जाते हैं after this week तो probably gradually सारी चीजें these are opened up now.
So, Dr. Salim, you're also practicing in Pakistan, in Azad Jammu Kashmir. What is your feeling and experience?
Yeah, this lockdown is very important because in Azad Jammu and Kashmir, this is our 4th week of lockdown. And here the people are abiding by very good over routes to the Pakistan. There is very tight screening. And we have just almost 48 cases till now. And most of them, they were imported. People came from the UK and from other European countries. And we had very little local transmission here. And I think if this lockdown is observed, it is very helpful. I watch on television in certain areas of Karachi, you see that there is, in spite of lockdown, that is not being observed. And as Professor Shamsa is mentioning about Lahore, it was easy yesterday. So I think it should be observed. And it is very good.
Thank you. Dr. Rosina Munir, if you unmute yourself, do you have any comments on this? I think we're having trouble listening to you. You may have a different audio device selected for instead of your microphone in the settings. No, still not coming through. Dr. Kabani?
Well, I think the duration of the lockdown is probably going to be dependent on what location you're in. You know, right today in Houston, in they've been announcing that they're going to keep the schools closed, but they're going to start opening up the state parks at the businesses. But then in Harris County, where we live and is the medical center, very densely populated, the judge came out and said she is not going to lift the lockdown that quickly. So I think it's very location dependent, depending on the density and the number of cases. And the most important part is the testing and possibly testing with antibodies before we really start going. Economically, yes, absolutely, we need to get back to work, but will we stay at work if we do it very quickly? Dr. Kaleem, any comment?
Well, I think I totally agree with you. This disease is not just a medical and viral disease. This disease has so many different angles and impact on society. So every locality, every country and city, state, and Suba, they have to decide on the basis of what kind of number they have, what kind of education they have. As Farhan has mentioned earlier, the important thing is that if we have to take care of this disease, we have to practice the basic infection prevention protocols. What does it mean? Hand hygiene. And now everybody is advocating wearing the face mask. So looking at the studies, the highest transmission of the disease happened among the household contact. तो अगर आपने लॉकडाउन करके अपनी सारी बिजनेसेस को बंद कर दिया, आपके गरीब जो हैं वो भूखे मर रहे हैं, लेकिन आप जो है वो सोशल डिस्टेंसिंग जो है अपने घर में नहीं कर रहे हैं, आप मास्क नहीं पहन रहे हैं, आप ग्रोसरी स्टोर में जाकर दूसरों को लगा रहे हैं, तो one society has to think through all these things. The second highest thing which we have observed is in the healthcare provider who are not using PPE, or workplace gathering में and the social contact में these things has seen. So I think हमें खुद learn करना पड़ेगा कि what kind of balance we have to take so that we can continue to survive as a humanity and also try to prevent ourselves from the disease.
Any comments from Dr. Morton or Dr. Kadeem?
Assalamualaikum. In our institution, we are hearing mixed messages like every place else. Social distancing and lockdown is still in full force. They're expecting the virus to level off for at least a couple of weeks before they will let go of the local lockdown in here.
Farhan?
नहीं, मैं कलीम भाई से बिल्कुल एग्री करता हूँ. मेरा बैकग्राउंड जो है वो बिजनेस से है, so I know how much does it hurt the business, my family back home. और at the same time लोग अब जो है प्रोटेस्ट करके बाहर जा रहे हैं, but they're not following the social distancing as they should. और I still believe that it's a very fine balance. It's a very difficult situation, and I just pray that we get over it sooner than later. And hopeful that, I think the most important thing is that everyone has to take the responsibility individually, and then we can tackle this.
Thank you so much, Farhan. And I think we are 15-16 minutes over our time, like most days. I want to thank Dr. Kaleem for stepping in and answering questions so well, and panelists. And thank you, attendees, for joining us and staying throughout. Please join us as panelists and speaker. Write to us, suggest speakers to us, and we will see you tomorrow. Thank you so much. Thank you, everyone.
Okay. Assalamu alaikum. Thank you.
Thank you. Assalamu alaikum.
Assalamu alaikum.